Thank you very much for permitting me to be with you with these huge organizations and a lot of good compliment I would like to tell to you. So my purpose is to open your eyes about something that's very important in the medicine practicing, and that is for more and more forgiven. So I will start with in the antiquity, the diagnosis has a divinatory value that gives a meaning to the days. People didn't know what was about the days. So with these guys, it was possible to make divination about what could happen. And then, since we could die for anything, it was comforting to know that we would not die for nothing. Later, the Hippocratic physicians and their Roman and Arabic successors describe and called the diseases with a precision that still surprises us today. The diagnosis had the beauty of an art, therefore the doctor was forgiven for his total lack of efficiency on biological and medical outcome of the patient. This art has progressively acquired a meticulousness, almost bordering obsession during the Enlightenment century, when the methodological nosology listed in 10 classes, 44 orders, 350 genera, 2,400 species and disease. Patients always died because of lack of treatment, but were comforted by the fact that the doctor was as knowledgeable as an entomologist. Later, on the a little later, the anatomo-clinical method using cadaver dissection, and the diagnosis became very medical and very precise with the aim to correlate location and causes of the disease and the death. There are a lot of books that has been written at this decision. In the particular, this Morgani, who has done 700 dissections for during 60 years of work, and explaining what was in the cadaver, and try to explain what was in the cadaver could explain what was the diseases. The examination of a cadaver is of one single man who died from a chronic disease is more useful to medicine than the dissections of 10 hangmen. The hangman was dissected to see what was inside their body, but they were not necessarily ill with a pathology. So what was interesting is to have the cadaver somebody who has been healed. That's the revolution of this century. Patients died without treatment, but with certainties wasn't a part of the ideals that so many religions were seeking for long. Then we are in the 19th century, the release of surgery by general anesthesia, the Pasteurian revolution, discovery of antisepsis, discovery of the X-rays, discovery of insulin, discovery of the DNA, and so on. In fact, miracles of exponential scientific development have brutally broken the lascivious harmony of all this art of the diagnosis. Finally, the market society has completely eliminated therapeutic inertia. There was no longer any diagnosis without immediate medical action. Nice adage for the market. Even if the patient is nothing, we could always do something. In the past, today, the treatment can precede the diagnosis. We discover abnormalities ignored by the science and a number of carriers that are more common than neither doctors nor patients could imagine. We just have to give them a name and to detect the carriers. While the diagnosis has been cherished and promoted to the detriment of therapy, the new art of therapy has been able to drag diagnosis in its wake. Now we can detect and evaluate the risk of certain disease, often rare and transmissible, and the evolution of the less aggressive, such as certain cancers, could be controlled before they appear. In the past, the preeminence of diagnosis allowed us to die with certainties. The new preeminence of therapy affords to have these certainties much earlier. What's about technological and knowledge, actually? The art of healing in the 21st century seems to have entered in a vicious circle. Exponential development of scientific knowledge and diagnostic and treatment tools, comparable curve diversification with inexorable compartmentalization, and very important development of more and more sophisticated and diversified specialties. Unfortunately, everything more and more organized in clusters. The art of in the 19th, the surgeon did everything. He was the one who knew how to incise with developed surgeon's tool. The first having been the barber's razor till the 18th. In 1980, there were this kind of surgery, about 6: digestive, general, plastic, reconstructive, neuro, orthopedics, and urology. But the surgeons were general practitioners in each of their specialty. Actually, there is a huge splintering into a nebula of specialties. For example, orthopedic surgery, the orthopedic surgery, and digestive surgery, another. For the orthopedic surgery, you have hand surgery, shoulder, hip, knee, foot surgery. But there is something missing here. I'll let you guess what it is. Oh, sorry. This is the elbow surgery. Elbow surgery. So no specialist in elbow surgery. You won't never find in the list of surgeons elbow surgery. So when you send a patient to the shoulder, surgeon says, it's not my area. I don't touch it. Okay, let's try it with the hand surgery. No, I don't do this, the elbows. And you have to find 1 or 2 hand surgeons that are still working in both of the joints, right? This is the natural effect of all this new system of the function of our healthcare. If a patient comes to the hospital, we have about 200 specialties to find. If the patient has been well referred as he should be, then there is no problem. You will find a surgeon or the specialist for fixing the problem. But if he doesn't know, and there is some of them, they are seen by a surgeon, and if they are lost, patients are lost or referred in the wrong door, the specialist consulted for error or referral first investigate in his cluster with his sometimes very expensive evaluation methods, and finally declares that it is not within his field of action. The patient is then referred to another specialist, or as hopefully find out the right one, which not always is the case, and so on. Now, some words about economy and art of healing. Ideally, it should be possible to continuously improve the quality of care and equity of access to care and reduce costs without one of these dimensions undermining the other. The art of healing in its lofty conception is now confronted with the realism of economics and financing. Economization is characterized by the orientation of the structures, processes, and resource structures according to the principle of efficiency, with the search of the most favorable ratio of cost to results. Saved resource remaining at the disposal and may have to be at disposal of solidarity system. On the other hand, the quest of the only worry to maximize earnings in order to be re-injected in the system without any benefits other than for the partners in the financial package is known as commercialization. And it's not the same. With a consequent setbacks caused by the implacable rules of return on investment, which means questionable practice in a spirit of profit. A state of mind that seems to spread in recent years, with an operating mechanism where the indulgence and passivity of the system are to be condemned in the face of certain practice incompatible with the notion of probity required by our noble art of healing. And then, a simple little idea or unrealistic ideal. In our osteoarticular pathology specialty, we are surprised by the obstacle course of certain patients, even though the diagnosis was obvious. Only by the simple efficiency of an attentive listening of the history, the complaints, and the answers to the directed interrogation, and especially the effort to be made in the exercise of this clinical examination. It has to be systematic, rigorous, and this whatever the concerned body part. 80 to 90% of efficiency without machine. Providing high performance in diagnostic approach. Usefully orienting the patient to the right investigations and correcting their irrelevant findings. So we know that the physician who starts working experiences an unpleasant feeling, and in medicine the starting out takes a long time. This unpleasant feeling in front of a patient who suffers, from whom the diagnosis must be made and be the right one, which naturally pushes him towards the comfort zone of systematic investigation. Okay, it looks right, but, and the literature is confirming our clinical experience, with shoulder and what we call asymptomatic rotor cuff of tears, RCT, review the prevalence of asymptomatic partial thickness or full thickness RCTs. 8 to 40% of normal population without any symptoms are living with these abnormalities that are subject to operation. And we see that. They are coming by us. I don't understand. He has operated me and it's still aching. So this was a medical mistake because of the lack of the clinical approach. This is the main message of this meeting. In general, the prevalence of asymptomatic RCTs increases with age. The older the patient is, the most there is possible misunderstanding and misuse of the medicine. For the knee, asymptomatic meniscus tear, prospective cohort study, prevalence of abnormal findings in 230 knees of asymptomatic adults. 230 knees of 115 injured sedentary adults. 51 males, 64 females, median age 44 years. Prevalence of asymptomatic meniscal tears were 30 in knees. We have patients that we send to the X-rays, MRI, because we are looking for something else. We know that we are looking for anything. And when they come back with, you were right, this is, for example, one diagnosis. By the way, we have encountered that there has a meniscal tear or ACL tear. But this ACL and this meniscus were not the source of the complaint. So we know that this MRI, if this MRI would have been put in the hand of a surgeon, it was, for some surgeon, an indication of surgery. And the conclusion of this review of these experiences, both of the authors are telling in 2019 and 2020, very recently, despite the increasing use of the high resolution in MRI, in practice, diagnosis should be primarily based on patient's medical history, physical examination and by an experienced clinician, instead of solely focusing on the MRI results. The images may assist in correlation clinical signs and symptoms, but should not replace clinical evaluation. This is the main message. So it was the knee and the shoulder. Yes, the knee, meniscus tear, ACL tear, the hip, arthritis, force, arthritis, asymptomatic shoulder, rotator cuff tears, but they are not symptomatic, lumbar spine, disc hernia. There are huge disc hernia in some spines that are not symptomatic. It's not the pictures that is the reality. Alas, even when we mature, and this whatever our specialization in the art of healing, it seems more and more that we are practicing with forgetting the first steps towards the good diagnosis, namely those of the fundamental principle of semiology, interrogation, and rigorous clinical examination. This systematic practice allows, even when we believe that we have guessed the diagnosis, all along the path of a career of a doctor, to develop clinical common sense or precious sixth sense, which for the moment no machine can replace. So, remember, we only treat well what we know well. Eyes don't see what the mind doesn't know. You have to know all the diagnoses before examining and try to find another one or repair the one you know. The patient who feels listened to is already relieved. A brilliant diagnosis without explanation is less efficient. Better a good decision than a nice decision. Medicine without the spirit of duty to seize the diagnosis before the artifices of technology is only ruin of the soul. Humility and uncertainties are better than pretension and self-confidence. Oops, I'm going back. So thank you.